We have all experienced at some point in time a routine skin injury, such as a mild burn or skin tear, and we might have been afraid that it would leave a lasting scar. But to our amazement, the body can fully repair itself. Well, most times. But sometimes wounds can be more complicated and challenging if they are caused by diabetes, surgical interventions, or post-op complications. Luckily, there's a tremendous amount of research being done to better understand the physiology and the mechanism of action for wound healing so that we as physicians can deliver improved medical and cosmetic outcomes for our patients. Today, we are going to explore wound healing, a field that happens to be very heavily impacted by dermatologists. I'm very excited to be talking with Dr. Robert Kirsner, who is one of the leading dermatology experts on the topic. Dr. Kirsner is the Chief of Dermatology at the University of Miami and the Director of Wound Care. He serves on the editorial boards for a number of journals in dermatology and wound healing and is the academic editor of the journal, Wound Repair and Regeneration. He also currently serves on the board of directors for the American Academy of Dermatology and the Wound Healing Society, and is the past president of the Association for the Advancement of Wound Care. Dr. Kirsner, it is a pleasure to have you on the Derm Club podcast today.
Thank you, Hannah. It's great to be here and to talk about one of my favorite subjects, wound healing.
Great. So let's get started. We're going to just start with some basics. Can you talk about the background of wound care and what it entails?
Certainly. I think if you go to the textbooks, you read about the 3 or actually 4 phases of wound healing: coagulation or hemostasis, inflammation, proliferation, and then remodeling. And each one of those phases are really have phases within them where cells come in and go out, and wound healing is accomplished. But that's really pretty dry. I think wound healing comes to life when you think about the patients we encounter, and being a dermatologist, we often see many patients that we don't think of them as having wound problems. We think of having skin diseases or skin problems, but really wounds are the consequence. So for example, if you have somebody with an autoimmune blistering disease like pemphigus vulgaris, that's a wound that you have to heal. If you have somebody with a severe drug reaction, toxic epidermal necrolysis, that's a wound you have to heal. Vasculitis, which is an inflammation of the blood vessels, that's a wound that you have to heal. So many aspects across all of dermatology leads to people with wounds. And it's therefore imperative that all doctors, but especially I think dermatologists, become at least comfortable with understanding and dealing with wounds, because they're going to be able to help their patients. And I think the minute you get a passion, the minute you take an interest, then you'll seek out answers from books or from journals to try to help you deal with patients' problems.
So wounds are like the underlying, you don't realize that wound care is involved in almost anything you're doing in dermatology. And it's really important to understand and to know how to do proper wound care so that you can give the best results to the patient. I want to talk a little bit with you about opioids. There was an epidemic of overprescribing opioids, and I understand that this was also the case amongst dermatologists prescribing opioids to patients who had just undergone, say, Mohs surgery. Why are they being overprescribed by dermatologists? I was always told the best painkiller is time and Tylenol.
Yeah, so that's a great question, and we've had an interest in this for a while. I think the world changed 15 years ago, and what happened was that pain became the 5th vital sign. And it was in all hospitals throughout the country. In addition to taking blood pressure and pulse and respiration, etc., they would assess pain. And hospitals and physicians were judged on the ability to reduce pain or prevent people from having pain. So it became part of the culture. And people said, well, if pain is being viewed as being so important, just like blood pressure, we really need to take it seriously. And people kind of upped the ante when it came to suppressing pain. At the same time, obviously, there were other issues going on, like the pharmaceutical industry were making pain medications and were promoting them. And of course, that resulted in this opioid epidemic. But I think the surgeons, one of the things that patients rate their surgeon is how much or little pain they had. Yes, they want their cancer out. Yes, they want their lesion removed. Yes, they want their scar to look good. But they also don't want to experience discomfort either during or after surgery. So the not knowing that opioids had long-term consequences or short-term consequences, a lot of dermatologic surgeons got used to prescribing opioids. And they thought that they were on the cutting edge of care because they were making sure that patients didn't have pain. Well, what we've learned is that there are a lot of bad consequences of opioids. Certainly, we can list the number of people who have succumbed, famous people, Prince and Tom Petty and many others who died from opioid overdoses. But even for patients who undergo surgery, what we've learned is that opioids slow healing. And so when you put a patient on an opioid after surgery, you actually delay the healing and increase the risk of wound complications such as dehiscence. So now we have to relearn what we thought we learned 15 years ago, that we should suppress pain at all costs, to really learning that we should reduce pain, but properly, and avoid opioids if we possibly can because of the negative consequences of them.
What is the mechanism of action behind why opioids impair wound healing?
It's not entirely clear. So there's a fair bit of work going into it. It may be disrupting the normal inflammatory and nociceptive pathways that drive wound repair. The simplest idea is that it experimentally, substance P speeds healing in vitro models and animal models, and opioids inhibit substance P. So it's possible that substance P may be a key player. Additionally, in addition to kind of the biochemistry and the physiology, it's also may have psychological and behavioral changes that may occur. So, perhaps if you have a wound and you're taking opioids, you may bump it more frequently or trip more frequently, and you may have more trauma. So there are probably a lot of things that come to play when it comes to why opioids impair healing. But at least in 2022, the message is if we can avoid prescribing opioids to patients, their wound healing will be better.
So what do you, certain wounds can be very painful, specifically venous leg ulcers. How do you counsel patients against taking opioids? I'm sure you get asked by your patients often, oh, doctor, could you prescribe me a painkiller? This is so painful, I can't even stand it. What do you do?
Yeah, so I think that the first thing is you want to understand why people are having pain. Sometimes people are having pain because of ischemia, and you want to make sure that that's not the cause of it. Sometimes people are having pain because they have an infection, so you want to treat the infection. Sometimes they're having pain because they have excessive inflammation. For example, the condition pyoderma gangrenosum is quite painful, and that's because of the excessive inflammation. But many people have pain because their wound is open, the nerves are exposed, and because of that, we try to focus on what is causing the pain, and because nerve pain is an important part of many of the wound healing conditions, such as venous leg ulcers. It turns out that the swelling associated with venous insufficiency probably damages nerves or to some extent, and probably causes a little bit of a compression neuropathy, and patients often have a burning pain associated with their venous leg ulcers. So we often use drugs such as pregabalin, for example, or gabapentin to kind of quiet the nerves and not only treat pain, but actually, if you take it on a regular basis, prevent pain. And once they heal their wounds, many times they will then be able to come off the pain medicine and go about their business.
So, along the similar lines to painkillers, can we talk a little bit about topical cannabis? And if you have any experience using it for wound pain and what your opinion is on this?
So it turns out that interest, both medical and recreational use of cannabis, especially the medical use of it, is really coming at, in some ways, the right time, because we need other drugs that can augment our armamentarium. And while there's a certain degree of baggage associated with cannabis use, targeting that pathway can be quite effective for a variety of conditions, including pain. So while there haven't been a plethora of robust studies yet, there have been publications and clinical experience about using topical cannabis with success in patients with pain. And as I mentioned, pyoderma gangrenosum before, there is, for example, a case series of using topical cannabis for that condition. So I think that this is a very hot topic. People are studying this. Obviously, because it's of public interest, a lot of people are getting into the field. Sometimes the formulations are imperfect. Sometimes the delivery systems are imperfect. But I have no doubt that if we fast forwarded 5 or 10 years, the use of cannabis topically and in some situations systemically will probably be much more routine than it is now.
Are there any other drugs in the pipeline or within clinical trials right now that are for wound care pain?
Well, I think that anti-inflammatories, I think we're learning a lot about the role of inflammation in pain. And I think that a variety of different anti-inflammatories are trying to be repurposed for wound healing. Some of them are simple, topical acetaminophen, for example, topical indomethacin, for example, and some are more complicated anti-inflammatory drugs. But I think that that's going to be another group of drugs that are going to be brought to bear to help wound pain. And in the wound healing field, we often think about pain in several different situations. One is the constant pain people have, but then there's pain, episodic pain, where people may have pain when you do a procedure like debridement. People may have pain when you do a dressing change. And sometimes people have done very novel ways to try to address the pain. In our department, one of our junior faculty, Dr. Hadar Lev-Tov, is studying the use of virtual reality as a distraction for people who are having procedures done. So he puts them in this virtual reality world. They're actively participating, and they're able to carry out procedures very easily, both in adults and in children. And patients barely perceive the pain because their brain is focused on something else. And there have been studies, in burn wounds about the benefit of virtual reality and physical rehab.
So fascinating. Yeah, when I was a cutaneous oncology fellow, we had a patient who had melanoma metastasizing up and down her leg. And I remember we were using a treatment called TVEC to inject into the to the lesions. And this was very, very painful for the patient. The injections, it had a strong burn feeling, and they just couldn't stand it. So we would start prepping the patients with numbing ointment. And I didn't see like great results with the numbing. It was very minimal. So I think we definitely need some better options there. And maybe there are that I just don't know of.
Right. No, I think that it's an evolving field. And the good news is many of the companies involved with wound care are beginning to focus their attention on finding solutions to this problem. And I think that the future is optimistic.
Great. So let's switch gears a little bit and talk about skin grafting. Can you share with us the advantages and disadvantages, and what is the recurrence of venous leg ulcers like?
Right. So it turns out that I've had a longstanding interest in skin grafting my whole career. And I remember doing split thickness skin grafting as a wound healing fellow, 30 plus years ago. And it was a great sense of accomplishment when you could put a piece of skin on a patient. They had a longstanding wound, that skin takes, and people do great with it. The problem is that not everybody is like that. So while about 50% of people get complete closure of their non-healing wound, and another 20% plus or minus get improvement of the wound, meaning it gets smaller, not everybody heals and not everybody improves. And it comes at a cost. The cost is that you have to take a donor site, and you're left with a resultant second wound. And oftentimes you have to do these procedures in operating rooms. So there's cost of, a financial cost associated with it. So skin grafting in some ways is a high risk procedure because it risks finances, it risks the donor site, and it risks not having perfect outcomes. As an answer to that, people developed what they used to call skin substitutes, and now people call them cell and tissue-based products, or CTPs. And I was very fortunate because I was in the right place at the right time, but I was the first person to ever apply this skin substitute, or at the time, a bilayered living skin equivalent called Apligraf, to a patient, to a real patient. My mentors, Vince Falanga and Bill Eaglestein, were working with the company that developed this. They handed it to me and they said, put it on a patient. And this was 7 years before it got FDA approved as the first cellular skin substitute product. And it's been saved many, many patients from wounds, from amputations, and probably lives because of that. But people said, well, let's develop an off-the-shelf product for wound healing. And a lot of them have been developed. But now fast forward, other people have said, well, off-the-shelf products are good, but maybe a patient's own skin is still the gold standard. Mm-hmm. And people are trying to develop new techniques to reduce the risk of that high-risk skin grafting procedure. And several things have emerged. One is one called epidermal grafting, where you put a device on somebody's leg, you apply suction, and you can separate the epidermis and transfer just the epidermis. And the epidermis heals without scarring, regenerates. So the donor site heals beautifully. It can be done without anesthesia, and the risk is low because if it fails, you can always go back and do it again, but it seems to work fairly well. The other approach has been to take very, very slim or thin pieces of skin graft using the concept of fractional lasers, where you create a laser wound that's so thin it heals without scarring. They've taken that thin piece of skin, and instead of lasering and destroying it, they would pull it up and then place it onto the wound and deliver the cells and growth factors that piece of skin has. And at the same time, the donor site heals very nicely with little or no scarring. So there's been this kind of shift back to autologous grafting because we're able to reduce the risk and make it a lower risk procedure.
It's just fascinating. My grandmother, who is turning 95, obviously she has very fragile and thin skin, as most elderly people do. She bumped into something, her skin sloughed off on her leg, a big chunk of skin came off. And what we actually did was we took that piece of skin, put it back on, and put some compression gauze on it. And within about a month, it healed beautifully. And it's the same idea.
Is
So
exactly right. And I think that what we've learned over the years is that, for example, if you have a blister, you want to leave the blister intact because it's a biologic dressing and it delivers growth factors and cytokines and keeps the wound moist. And we don't remove blisters unless they're, painful. And we've tried to teach the burn surgeons that concept, that not every part of a burn wound needs to be debrided. Yes, the necrotic tissue does, but if you have intact skin that's blistered, leaving that in place is probably a better approach.
what is the typical timeline for healing for skin grafts, and what impairs this healing timeline?
So skin grafts are done for two reasons. The first is if you have a big surgical wound and you can't close it. And so in those situations, you're putting skin into a freshly made, what we call acute wound. And those do very, very well most of the time. Sometimes we try to replace the full thickness of the skin because that gives a great cosmetic result. And sometimes you don't get quite enough nourishment from the wound bed to nourish the entire skin graft, and the top may die a little bit and then has to regrow. But oftentimes we put skin onto diseased areas. So we put it onto wounds that are from venous leg ulcers or pressure ulcers. In those cases, there's underlying problems that have led to the wound. There may be bacteria present. There may be excessive inflammation. There may be poor blood supply. And that makes the taking of the skin graft, a little bit more tenuous. And that leads to failure. If it succeeds, generally you can put it on and a week later you see the skin there. And then you have to treat it with tender, loving care for probably a couple to 3 months because the skin needs time to mature and really take hold. If you can get out past 2 or 3 months, the likelihood is that skin's going to stay longer term. But you'll see, but there's still that period of time where you have to kind of baby the skin graft recipient area.
Does the donor site matter, and does it matter the location that the graft is taken from?
So it might. There's some data that's emerged that if you can harness all of the healing power from the donor skin, you may have a better graft. And we generally think that when we're harvesting the skin, we're taking the top layer, the epidermis, and maybe part of the dermis, or in some situations. But we're learned that the hair follicles have a lot of stem cells in them, and they add a kind of a boost to the skin graft. And we and others have done both experience and studies that have shown that if you can include the hair follicle in the graft, then the results might be even better because you're augmenting the cells that are in the epidermis with these kind of stem cells that are in the hair follicle.
So if we know hair follicles have stem cells that stimulate wound healing, is there a reason we haven't started cloning these types of cells?
So it's a good idea, and one that was tried with some success a number of years ago. What they did at the time was that they would pluck people's hair, they would take it to the lab and let the hair grow into a petri dish so that those cells came from the hair follicle, and then they were able to be applied later on to a patient with a wound. And the results were quite good. I just think that sometimes good ideas are not at the right time. And I would imagine that if you fast forward, technologies that harness that idea of taking the best cells we have, whether they're stem cells from hair follicles or stem cells from other places, and growing them, that's probably going to be more and more part of our armamentarium to heal wounds.
How does stress impair wound healing? You often hear that stress really takes a toll on our body, and people sometimes think it's a myth, but how does it impair wound healing?
Well, as you pointed out in the beginning, wound healing is a miraculous process. And oftentimes you see the same things in the microcosm of a wound that you just described. So it turns out that stress impairs wound healing. In fact, in healthy people, it impairs it by 40 or 50%. They did experiments in college kids, and they wounded the college kids when they first got to campus, and they're seeing their friends and they're having a good time, and they heal great. And then they take those same kids and heal them in the same way right around finals. And it takes them 40% longer to heal those wounds. So we know that stress impairs wound healing, and has been associated with impaired wound healing in both acute and chronic wounds. And there's a lot of experimental data. So it's important that we try to overcome stress, reduce stress in our patients. One of the things that people have tried to do is reduce the pain and the associated with wounds. Of course, we don't want to reduce it with opioids, but we want to make it as pleasant as possible. And we do know that people that are less stressed, people who exercise, people who have a friend network, people who are more socially engaged, do better, heal faster than their counterparts that don't have those characteristics. It turns out that we're learning the science, and the science seems that a lot of that improved healing is related to the hormone that many people know as the love hormone, oxytocin. And oftentimes, if you can, oxytocin is critical in speeding the healing. The problem is oxytocin has a very short half-life, and if you use it chronically, there are some untold effects with oxytocin. But we are learning the science around it.
So now we know the science about, or we're learning the science about stress behind wound healing. Is this the same idea of why there's a difference in wound healing between young adults or young children and elderly patients?
Yeah, so as we all know, and your grandmother was an example, is that young people and old people heal differently. Old people heal slower, but they also have less scarring, interestingly enough. And a lot of that healing and scarring is mediated by certain hormones such as estrogen. And very elegant experiments were done in women that were young, and women that were postmenopausal, and then women who were on hormone replacement therapy being postmenopausal. And what was learned was that the young people heal better, faster than the older people, but they have more scarring. But if the older women who are on hormone replacement, they healed more like young people. They healed faster, but had more scarring. And it turns out it's not just women. Men, in a similar fashion, if you the healing is mediated by estrogen. And if you add estrogen to an older man's wound, they'll heal faster, but with more scarring.
What are your tips for avoiding scarring? I know that's a very broad, lengthy question, but.
Well, fortunately, there are great people all throughout the country that are studying the mechanisms of scarring. And one of the driving forces has been the knowledge that if you wound a fetus in utero, it heals without scarring. So people have said, well, why is that? What happens in the first 2 trimesters of in utero that is different than later on, both in utero and in life? And a lot of ideas have emerged, but pathways and ways to target those pathways have been developed. One of the things is physical tension. It turns out that in early fetal life, there's a very fluid and kind of aqueous environment the cells live in, and there's less tension and less stimulation of certain proteins like focal adhesion kinase. When you're born, and then as you grow, you have much more tension of the skin. So if you can alleviate tension of the skin, you reduce scarring. We do it all the time in dermatologic surgery, and other surgeons do it through undermining or releasing the tension, right? We try to make incisions on tension lines to reduce the tension. People have tried to use botulinum toxin to reduce the tension and improve the scarring. All of those are possibilities in improving scarring, as is certain new dressings that can be placed on a wound and reduce the tension on that suture line to give a better cosmetic result of that suture line.
Do you find yourself using any types of lasers once the wound has completely healed?
So, as I kind of briefly alluded to, there is this idea of these very thin fractional lasers that create these very thin wounds. And what happens is they're so thin that they heal without scarring. So not only can they heal without scarring, but they can take a scar and make it heal normally. So oftentimes we'll use various lasers. Sometimes, depending on the problem, we may use vascular lasers, we may use fractional lasers to help patients, either scars from trauma or scars from surgical wounds. So it's part of the spectrum of wound care.
When it comes to suturing, superficial versus deep sutures, do you recommend doing both deep and superficial sutures to decrease the risk of a scar and improve wound healing? What is your opinion?
It's you bring up a very interesting point, because a lot of the things we take as kind of common knowledge, we learn over time that they may not be true. So when I was growing up, people used to have tonsillectomies all the time, and now we know that people do equally well whether you take out their tonsils or not, and that's kind of fallen by the wayside. And so for years we would put deep sutures in, and then we put the top sutures in. And we had a whole rationale about how we would avert the wound edges. And as it healed, the wound edges would flatten and you'd get a better cosmetic scar and the wound would do better. But it turns out there's been a series of studies that have been carried out over the last 5 or so years that have challenged that idea. If you put deep sutures in and you put them in well, the addition of top sutures may not be necessary. And oftentimes the wound actually looks better if you don't put those top sutures in. But it's really hard to change people's behavior. If you've been doing that for 30 years with success, you're not likely to change. And many of those people who are teaching future generations are teaching them the way they used to do it, as opposed to perhaps based on the new knowledge. So that's changing people's behaviors is a real challenge. And I think it's going to take a while before we see people abandoning top sutures.
Fascinating. So I mentioned to you in the beginning, I am writing a paper right now on venous leg ulcers and about the effectiveness of the most commonly used antimicrobial topicals against microbes of venous leg ulcers. So I just, there's so many mixed opinions out there. I've spent a lot of time with different physicians, different dermatologists, surgeons, who they'll tell after surgery or biopsy, they'll tell their patient, okay, don't use anything but Vaseline. Or avoid, sometimes they say avoid a Band-Aid because you might get a contact dermatitis from it. Then I've worked with other dermatologists who say use bacitracin, use polymyxin B. There seems to be just like a variety of opinions on what to use after you have after you close up a wound. And it just seems like there's no consistency. So what is your opinion? What do you find that has the best outcome?
Right. So there's a difference between acute wounds and and chronic wounds like venous leg ulcers, because chronic wounds have bacteria on them, and if they're colonized with bacteria. The mere presence of bacteria is not a bad thing, and most of them heal with that bacteria there. But acute wounds, in general, people think, well, they shouldn't be infected, okay, and we should keep a bacteria out, at least to the best of our abilities. So what we've learned over the last 50 or 60 years is the state of the art currently is to use some type of occlusive dressing to prevent the outside world from contaminating it and creating an environment that fosters faster healing by keeping it moist, by maintaining the electrical gradient, that keeping growth factors and cytokines in close proximity to the wound that needs to be healed. And so dressings are probably the best, that occlusive dressings are probably the gold standard. Now, some people will use Vaseline or other ointments because they do have some occlusive properties. But there's not much data, at least currently, to suggest that in an uninfected wound that the addition of an antimicrobial makes a difference. There's been a number of kind of landmark studies that suggest that if you're going to use an ointment versus an antibiotic ointment, there may not be a difference. And if you're going to use a dressing, there's no additional benefit of adding an ointment underneath that dressing. The dressing does what it needs to do and gives the results you want.
Okay, and are you concerned about having antimicrobial resistance to these?
So that's always the dark side of the coin, is that not only does you don't have benefit from it, is it actually doing harm? And in theory, the potential is there. In any one patient, you're not going to get resistance in that patient. But if every doctor starts using antimicrobials willy-nilly, then in the community, the resistance may emerge.
I've also seen some dermatologists where the patients, they just had a procedure done on their leg to remove a skin cancer, and they come in about 10 days later, it's red around the area. They don't have any systemic signs of infection. They have no fever, but they just have a warm red area. And they immediately put them on 2 oral antibiotics. Do you think that's necessary, or should we be giving the wound more time to heal at that point? Maybe using topicals before we give something systemic. There's I think in the next 10 years, there will be a big push to try to reduce the amount of antibiotics that we're giving out.
Yeah, so it turns out the scenario you said was lower wounds have a tough time healing. And one of the pearls is that if we can add compression and reduce the swelling and edema associated with the wounds in the legs, you'll get much better outcomes. And a lot of that redness will go away with compression, because a lot of what you're seeing is inflammation and edema and not purely infection. Now, if they're tender, it's really warm, it's spreading redness. If they have fever, obviously they need antibiotics. But if you have some redness, sometimes just by adding compression, you could reduce the redness, reduce the swelling, and patients do fine on their own. And this is all part of this antibiotic stewardship that you alluded to.
What is your threshold for sending someone home on either say, I want you to use compression stockings or some other type of compression device? Do you wait until they come back, or do you do it automatically?
As long as they have good arterial blood supply, I put them in compression for lower extremity wounds, because most wounds occur on the legs. And there's a reason, because of that, both some venous insufficiency, but also gravitational forces. So compression not only treats any venous insufficiency, but reverses the effect of gravity. In essence, we're trying to turn legs into arms from a physiologic standpoint, because arm wounds do a lot better than leg wounds.
Okay, I just want to bring us back one more time to the discussion about Vaseline versus bacitracin. Do you ever find yourself using bacitracin? I know there's a big concern about, or even say Aquaphor, about producing a contact dermatitis from these ointments.
Yeah, so I generally use occlusive dressings. So if I do a surgery on someone, I'll put a occlusive dressing, and I usually use a polyurethane film that has a little island or a telfa in the middle, non-adhesive dressing. And I don't even use any ointments right on the wound, because the occlusive dressing creates a moist environment, and I leave that dressing on as long as it stays. So I don't change it as a routine. I don't tell them take it off tomorrow and change it. As long as it leaks and doesn't fall off, it doesn't leak and doesn't fall off, I leave it in place. And sometimes, optimally, they'll come back for their suture removal in a week or 10 days with the same dressing I placed on. And invariably, when that happens, the wound looks spectacular, and it heals as good as any other wound I create.
It's interesting because there used to be this idea that you don't want to cover a wound, that you want to let it breathe, and that there's a concern for trapping bacteria into that wound. But I guess that's not the case at this time. It's actually doing the opposite.
As long as so there's a lot of interesting work, and it's very complicated, but the first is that if you don't, that Staph epidermidis may be a beneficial bacteria. That's number one. And even low levels of Staph aureus may help wounds heal cosmetically better. There's some very elegant work done that shows that if you create wounds in animals who are in sterile environments versus animals that are in normal environments, actually the animals in normal environments have better healed scars than the ones in sterile environments. So some degree of bacteria may not be a bad thing, but too much bacteria is problematic. Of course, this is experimental data, and it's probably, we don't want people to take the message that they should be rubbing around in dirt on their wounds. But it is interesting that some of the truths that we've learned are imperfect truths at best.
Do you ever find yourself using mupirocin?
So if I have a wound that's infected, but not cellulitic. So if there's some excessive drainage, if there's purulent material, if things of that nature, instead of using a systemic antibiotic, I may use a topical antimicrobial. And for impetigo, for example, mupirocin is equivalent to oral antibiotics. So that's often a preferred choice.
Where do you see the future of wound care and wound healing?
Well, I think that there are going to be three different areas that are going to grow substantially. The first is our ability to prevent wounds. And I think we're going to, because that's really the optimal situation. If we could prevent patients from having wounds, that's going to be, that'll be very, very important. And there are so many patients with wounds that it's going to be worth our effort in figuring out best ways to prevent wounds. The second is we're going to definitely utilize the technologies that are being developed in our labs to help wounds heal faster, and have them heal to greater extent. But I think the real sweet spot is going to, over the next 10 years, is going to be the quality of the healing. That we're going to have technologies that are going to allow us to heal wounds with substantially less scarring. And by have substantially less scarring, not only will that have a cosmetic effect, but by having more normal tissue, the likelihood of that wound having complications down the road, like reopening, is going to be diminished. Reduced pain, reduced itching. And I think that those three areas are going to be, there's going to be major advances, especially in our abilities to improve the quality of healing.
Don't you think that to completely eliminate a lot of the wounds that we see, that would require us decreasing diabetes?
Yeah, so I think that we're going to make inroads. For example, I'll give you an example for in venous leg ulcers. We know that reflux is an important part of the development of venous leg ulcers. Yet we don't often recommend people to treat that reflux before they develop ulcers. So having people think about treating those problematic veins prior to development ulcers may prevent more venous leg ulcers from developing. Better control of diabetes, or maybe even ways to restore the sensation in an insensate foot may help reduce the incidence of foot ulcers in the diabetic population. So I think there are many people in a very pluralistic way are looking at the problem in different ways to kind of solve this. I'll give you one example. One thing we know about diabetic foot ulcers is that repetitive trauma creates inflammation, which raises the temperature. So people are developing clothing and shoes and other tools to measure the temperature of the feet and to alert the patient that they're at risk for developing an ulcer before they develop it. And then now they can get off their foot, let their foot rest, and perhaps prevent the ulcer. So while doing better with diabetes is part of it, there may be other ways to reduce the incidence and prevent ulcers as well.
Incredible. Well, thank you so much, Dr. Kirsner. This was such an interesting conversation, and I really am happy that you were able to join us today.
It was great spending this time with you, Hannah, and thank you so much for inviting me.
I hope you enjoyed this episode of the Derm Club podcast. If you found the discussion today to be valuable, please subscribe and share. I look forward to seeing you in the next episode as we continue to delve into dermatology and skincare with the world experts.